Dear students, welcome to R.A.T.S Pathology, Racing Against Time. And this shall be the chapter on FGT including breast. In this session, I shall be covering two short questions or a short essay, leiomyoma and a granulosa cell tumor. These can be kept as specimens asked in the viva voce, important from OBG as well as MCQs. Leiomyoma, it is age old and definitely you people will be familiar. A benign tumor arising from the smooth muscle commonly seen in the female genital tract, that is uterus and cervix. This is a very nice specimen picked up from Wikipedia, and the common sites of a leiomyoma include the uterus and cervix, gastrointestinal tract, blood vessels and ducts. These are all organs or tissues which have got a smooth muscle from which the tumor can arise. Coming back to this tumor, it's a specimen of the uterus. I find that the external surface is bossellated, bulging out, and smooth. This is a stump of the cervix. The cut surface, the endometrial cavity is compressed, it is pushed to one side, and I am finding a large tumor towards one side. It has got a whorled appearance. We shall be seeing more of this later on. For your description, it will be apt if you can write what is on the screen. If you get a specimen of the leiomyoma, I'll go on with the theory part of it. There are multiple sites from which the leiomyoma or the fibroid, as it colloquially called, can arise. It may be submucosal, just beneath the mucosa, intramural, right within the muscle, or subserosal, beneath the serosa. Sometimes it can have a stalk-like structure from which it hangs. This is called a pedunculated leiomyoma. So here also I am seeing another peduncle with a tumor projecting into the endometrial cavity. These are the various sites. It will be nice if you people can draw it in your record. This is a specimen of the uterus with cervix showing the endometrial cavity. The uterus measures about so many centimeters, and then I am finding multiple leiomyomata or fibroid. So many of them are there. They are located within the cavity, within the intramural region, subserosal region, etc. And all of them are solid in appearance, grayish white, without any area of hemorrhage or necrosis. The microscopic picture, this is a very beautiful picture that you people can very easily draw. Look at the spindle-shaped cells. Spindle means they are all elongated, and the nuclei are also somewhat elongated, but they have got blunt ends. The ends are not sharp. So these are all bundles of spindle-shaped cells. And what is this one? This is a cut surface of the same bundle, and because of that, we see what is called an end-on view. It is as though we are looking at all the flats from an aerial view. Let me explain through this. This is a picture that we had seen, and these are the fingers. They are all elongated. The cells are all elongated. And there is another diagram showing how to draw a hand, but that's not my purpose. The fingers can be like this, or when they are cut across, you find that they are appearing just like small circles. That is exactly what we are seeing here. This is called an end-on view. We are likely to see this in the slide and we should not get confused. Why am I showing this particular diagram? This is a uterus, this is a broad ligament, etc. A tumor can arise from the uterus, subserosal region. It grows larger and larger and it gets landed in the broad ligament. So it travels from here. So this is called a migrating leiomyoma. And initially you find that there is the blood supply from the uterus. But later on, as it grows larger and larger, there is a ovarian artery from here. It derives the blood supply from there. So what began as an intrauterine leiomyoma turned out to be a wandering or a migrating leiomyoma, and finally a parasitic leiomyoma because it takes the blood supply from another blood vessel. And these are all the other things that we had seen. I will not be repeating it. This is a beautiful picture. Again, we can draw this one in the record. Look at this one. I would like you people to explain it also. This is a uterine cavity. This is the cardiac end, and you find that the muscle is so many centimeters. This is a large fibroid that has got a whorled appearance, solid, yellowish white or yellowish pink. And these are all elongated spindle shaped cells. This is the end on view. This is a basic diagram that you people should have, and on a smaller scale just keep repeating it and you get a leiomyoma. Elongated cells, then long nuclei with blunt ends. We used to describe them as cigar-shaped nuclei. So tumor cells are composed in bundles arranged in a whorled pattern. Nuclei are elongated with blunt ends. Cytoplasm is eosinophilic. Not much of pleomorphism or mitosis. The stroma might show hyaline change. A beautiful mounted specimen which I picked up, multiple leiomyomata, and the endometrial cavity is totally indistinct. Multiple fibroids of varying sizes, classical whorled appearance, and well demarcated. This is a counterpart of a leiomyoma. There is a malignancy. Look at this one. The cells are pleomorphic. I am seeing a large nucleus. And there are also some mitotic figures which are seen here. Lot of pleomorphism. And this is a picture of a leiomyosarcoma, the malignant counterpart of a leiomyoma. Look at the difference between this and this. And there can be other tumors in the female genital tract which are more or less similar. This is slightly more whitish. It has got a trabeculated appearance. Broad bands are crossing it. It will be very firm in consistency, and this is a fibroma. So in order to distinguish, we will be doing special stains. Please mention these two. Van Giesen is one stain where the muscle will be yellow, connective tissue red. So for a leiomyoma, the muscle will take up an yellow color. And another stain is a mesenteric where the muscle will be blue in color and the collagen is red in color. These two special stains, please mention Van Giesen and mesenteric. As I mentioned, the next topic for the day will be the granulosa cell tumor. This is again asked as a short essay. Usually the students tend to omit it. It is a sex cord stromal tumor, generally unilateral. It can be very tiny or microscopic or measure several centimeters in diameter and weigh several pounds. The tumor can be solid, cystic, or solid and cystic. Look at this one. It is a granulosa cell tumor. I am finding multiple blood-filled cystic spaces and there are some solid areas in between. There is another element of the sex cord, namely the theca cells, from which we can get a granulosa theca tumor or thecoma, which is more solid and yellowish, we shall be seeing. Here again, this is a granulosa cell tumor and it is appearing more solid with less of cystic spaces with gelatinous material. It is a functional ovarian tumor. It produces a lot of estrogen, as a result of which the patient will be presenting with abnormal uterine bleeding. There is endocrinologically active secretion of estrogen. It can become malignant, but it is difficult to diagnose histologically. Being estrogen producing, it can have other conditions such as fibrocystic disease of the breast. The patient can develop a carcinoma of the breast. The patients can also have a condition called endometrial hyperplasia and carcinoma. There is a metastasis in the pelvic region and the tumor marker for this is inhibin. Please remember this, as I mentioned earlier, markers are essential. Tumor marker is inhibin. Solid and cystic areas, areas of hemorrhage, functional tumor, and abnormal uterine bleeding. This is extremely important for us. So they appear from the follicles of the ovary. And here I am finding some remnant follicles, multiple of them are seen, and they are filled with proteinaceous material. They have got some cells which are perpendicularly arranged. And this particular structure is called a Karl-Exner body. Karl-Exner body is asked as a question or it can be an MCQ, and in GCT, granulosa cell tumor, you will have to mention. They resemble the Graafian follicles. This merges along with the surrounding connective tissue or the theca cells. The theca cells will be containing lipids, which shall be seen. This element I shall show you in the next slide. There are different histological patterns. These patterns kindly memorize. It can be diffuse, trabecular, glandular, watered silk, insular. Please remember this. Each one will fetch you a mark. These are all the various histological patterns. We need not go further into it. So this is the tumor which has got the various histological patterns. There is another variant of it called the juvenile granulosa cell tumor. In this, you find the Graafian follicles are somewhat irregular and large areas of proteinaceous material are seen. So it can be associated with precocious puberty, endometrial hyperplasia, and later on the patient can develop an endometrial carcinoma. Nuclear grooves or coffee bean appearance is less common. What is this coffee bean appearance? You find that there will be a split in the nucleus. That is what we are supposed to be seeing. If you see the cells carefully, there will be a nuclear groove. There is grooving of the nucleus, and this is described as a coffee bean appearance. The treatment for a granulosa cell tumor is surgery. Remove the tumor. But then, what will you do if the patient is very young? They do what is called as a fertility sparing surgery. Remove the bulk of the tumor and leave behind the normal tissue. Chemotherapy and radiotherapy are supplementary treatments. The prognosis is generally good and the tumor marker is inhibin. Please remember this. This has been asked as questions. Classify the tumors of the ovary and describe the granulosa cell tumor. And students generally omit these as it is in the latter half and pay the penalty. For completion, this is a thecoma. So these are the tumors arising from the adjoining cells, and there can be a combination called granulosa theca cell tumor. It is generally a benign tumor and it is yellowish because of lipid. Gracias.